Hi everyone, and welcome to our 6th webinar in the series. Our webinar today is on perinatal mental health, and my name is Danny, and I am a community engagement lead for the Cheshire Merseyside Women's and Children's Services Partnership, and work for the local maternity system. My colleagues Benin and Decca are here. Do you want to introduce yourselves?
Hi, my name is Benin, a community engagement lead, LMS team.
Hi, I'm Decca. I work with Benin and Danny with community engagement leads with the LMS.
Amazing, thank you so much. And we've got two amazing guests here with us today for our expert panel at the end. So Kieran, do you want to introduce yourself?
Hi, I'm Kieran Carter. I'm the perinatal mental health midwife at Southport and Ormskirk Hospital.
And Bev, do you want to introduce yourself?
Hi, I'm Bev Sapre. I'm a specialist perinatal consultant psychiatrist working in Cheshire Rural Specialist team.
Amazing, thank you so much for coming today and thank you for your help. The webinar series is to provide information, resources and support for all communities across Cheshire and Merseyside, discussing key health priorities to improve women's health. And like I said, today's session is on perinatal mental health. There's a short presentation just going through some of the key things of perinatal mental health, signs, symptoms and treatment. And then we're going to have a Q&A session at the end where you will all get an opportunity to ask any of us some questions, and we'll do our best to answer them for you. So, what is perinatal mental health? Perinatal mental health problems are those which occur during pregnancy or in the first year following the birth of a child. Perinatal mental illnesses affect up to 20% of new and expectant mums and covers a wide range of conditions. If left untreated, mental health issues can have a significant and long-lasting effect on the woman, the child and the wider family. And as more evidence emerges about the effects of perinatal mental health on the mother, father and developing fetus, the term perinatal mental health is now commonly used to describe the emotional well-being of women, their children, partner and families from conception through pregnancy to 1 year following the child's birth. 1 in 4 women are affected by perinatal mental health problems. And in 2020, maternal depression was still the leading cause of disability among women globally, and mental health problems in pregnancy and following childbirth are roughly now twice as common in low-income countries as they are in high-income countries. Maternal depression is the most common serious complication of the perinatal period. There are huge economic and human costs attached to global failure to act. Untreated maternal mental health problems can have a wide range of effects on women, their children, partners, and their significant others. Maternal suicide is the 3rd largest cause of direct maternal death in the first few weeks, but is the leading cause of death when looked at over the first year. Depression and anxiety are the most common mental health problems during pregnancy, with around about 12% of women experiencing depression and 13% experiencing anxiety at some point, and many will experience both. Recent UK estimates suggest population estimates of 11% of depressive disorders and 15% for anxiety disorders. Prevalence figures for postpartum depression vary, but are estimated to be around 13% in high-income countries and 20% in low and middle-income countries. Anxiety is highly prevalent in the postpartum period, affecting 10% of all women. Postpartum psychosis affects 1 in 2 in 1,000 women who give birth. Women with bipolar 1 disorder are at a particular risk, but postpartum psychosis can occur in women with no previous psychiatric history at all. Changes to body shape, including weight gain in pregnancy and after childbirth, may be a concern for women with an eating disorder. Although the prevalence of anorexia nervosa and bulimia nervosa is lower in pregnancy, the prevalence of binge eating disorder is higher. Around 11 to 12% of fathers will suffer from antenatal depression, and around 8 to 26% postnatal depression, giving an overall rate of about 9% of all fathers suffering from perinatal mental illness. However, with this being still a large stigma attached to it in fathers, this we think is actually under researched. So there are lots of common mental health conditions that you can get antenatally and postnatally, and the term perinatal mental illness includes a range of depression, anxiety, obsessive compulsive disorder, post-traumatic stress disorder, tocophobia, bipolar affective disorder, postpartum psychosis, eating disorders and personality disorders. And tocophobia is where women have an extreme fear of pregnancy that can lead to them avoiding childbirth altogether. The fear can become paralysing and terrifying and become physically and emotionally disabling. So the risk factors. There are many risk factors associated with perinatal mental illness, and these include past history of mental illness, a family history of mental illness, history of childhood trauma and poor parenting, antenatal depression or anxiety, pregnancy-related major life events or stresses, low social support, especially poor support from current partner, domestic abuse, substance misuse, relationship problems, major life events of our own mother, birth trauma, baby with specialist needs on a neonatal unit, teenage mothers, fathers, insecure environments, housing, financial worries, employment, debt, housing problems, natural disasters, earthquakes and extreme weathers, war conflict, long-standing personality vulnerabilities. So signs and symptoms, each one has very different signs and symptoms. Some of them do overlap. So what's the difference between the baby blues and postnatal depression? The baby blues is a brief period of low mood, feeling emotional and tearful around 3 to 10 days after you've given birth. You are likely to be coping with lots of new demands and getting little sleep, so it is natural to feel emotional and overwhelmed. This feeling usually only lasts for a few days and is generally quite manageable. However, postnatal depression is much deeper and the longer term depression. This usually develops within 6 weeks of giving birth, and it can be gradual or sudden, and it can range from being mild to very severe. So if you've got perinatal depression, you could feel down, upset or tearful, restless, agitated or irritable, guilty, worthless and down on yourself, empty and numb of any emotions at all, isolated and unable to relate to other people, finding no pleasure in life or things you usually enjoy, and a sense of unreality, no self-confidence or self-esteem, hopeless and despairing, hostile or indifferent to your partner and hostile or indifferent to your baby. And some can also suffer with suicidal feelings as well. With anxiety, it can affect your body and your mind. With the effects on your body, you can have a churning feeling in your stomach, feeling lightheaded or dizzy, pins and needles, feeling restless or unable to sit still, headaches, backache or other aches and pains, fast breathing, a fast thumping or irregular heartbeat, sweating or hot flushes, find it hard to sleep, grinding your teeth, especially at night, feeling sick or nauseous, needing the toilet more or less often, and changes in your sex drive and having panic attacks. And then more on the mind, you could be feeling tense, nervous or unable to relax, having a sense of dread or fearing the worst, feeling the world is speeding up or slowing down, and feeling other people can see you're anxious and looking at you, feeling that you can't stop worrying or that bad things will happen if you do stop worrying, worrying about anxiety itself, for example, worrying about when panic attacks might happen, wanting lots of reassurance from other people or worrying that people are angry or upset with you, worrying that you're losing touch with reality, worrying a lot about things that might happen in the future, thinking a lot about bad experiences or thinking over a situation again and again, feeling disconnected from your mind or body, or like you're watching someone else, feeling disconnected from the world around you, or like the world isn't real. So OCD. Obsessions are unwelcome thoughts, images, urges, or worries or doubts that repeatedly appear in your mind. They can make you feel very anxious, and although some people describe it as a mental discomfort rather than an anxiety. Compulsions are repetitive activities that you do to reduce the distress and anxiety caused by those obsessions. It could be something like repeatedly checking that you locked a door or repeating a specific phrase in your head. Repeating compulsions is often very time consuming, and the relief they give doesn't usually last very long. We all know it's normal to worry about your child's well-being and want to protect your baby while you're pregnant and after giving birth. But if you start to experience obsessive compulsive symptoms that affect your daily life and well-being, you may be experiencing perinatal OCD. The obsessions and compulsions you may experience are likely to relate to the feelings about being a parent or your baby. PTSD, where you are reliving aspects of your trauma, and these can include vivid flashbacks, about the trauma itself and like it's happening right now, intrusive thoughts and images, nightmares, intense distress that are real symbolic reminders of the trauma, physical sensations such as pain, sweating, nausea or trembling, alertness or feeling on edge, and they may include panicking when reminded of the trauma, being easily upset or angry, extreme alertness, sometimes known as hypervigilance, finding it hard to sleep, irritability or aggressive behaviours, finding it hard to concentrate, including on simple tasks, being jumpy or easily startled, self-destructive or reckless behaviour, and other symptoms of anxiety, and then avoiding feelings or memories altogether. Signs and symptoms of postpartum psychosis. The symptoms of postpartum psychosis usually start quite suddenly, within a few weeks after you've given birth. Postpartum means after childbirth. If you have postpartum psychosis, you are likely to experience a mix of psychosis, depression, and mania, and this means you may experience these common symptoms. You may feel excited or elated, severely depressed, rapid mood changes, confused or disorientated. And you may also start to behave restless, unable to sleep, unable to concentrate, experience psychotic symptoms like delusions or hallucinations. What are delusions and hallucinations? Delusions and hallucinations are aspects of psychosis which you may experience. Delusions are strong beliefs that other people don't share. For example, you might think you're being followed, your thoughts are being read, you are very powerful and able to influence things outside of your control, or you have a special insight or divine experiences. And some delusions can be very frightening, such as believing that someone is trying to control you or kill you. These sorts of delusions are often called paranoid thinking or paranoia. Hallucinations are when you experience things that others around you don't. For example, hearing voices, seeing visual hallucinations, and other unexplained sensations. So where can we go for treatment and what are the treatments? With appropriate treatment and support, most women make a full recovery, although it can take time. The three main types of treatment are self-help strategies, therapy, and medication. So we want everyone to talk to their GP about the pros and cons of different treatments so that you can decide together what is best for you. They may also want to check your physical health to see if there are any problems that may need to be addressed as well. For instance, you may be anemic after giving birth, and that could add to any feelings of depression that you also might have. Your midwife, GP or health visitor can refer you to your local IAP services, which is increased access to psychological therapies for counselling. Anyone who is pregnant or has a child under the age of 2 will be given priority. Your GP or specialist midwife can prescribe medications for you that you may be able to take during pregnancy and whilst breastfeeding. There are many medications and they can help you find the right one that suits you. Specialist perinatal mental health services provide care and treatment for women with complex mental health needs and support the developing relationship between parent and baby. They also offer women with mental health needs advice for planning a pregnancy next. Self-help for postnatal depression can be help looking after your baby can be stressful and challenge for anyone, and it can even be tougher if you're dealing with postnatal depression as well. There are a number of things you can try yourself to improve your symptoms and can help you cope. These include talking to your partner, friends and family. Try to help them understand how you're feeling and what they can do to support you. Not trying to be super mum, accept help from others when it's offered, and ask your loved ones if they can help look after the baby and do tasks such as housework, cooking and shopping. Make time for yourself. Try to do activities that you find relaxing and enjoyable, such as going for a walk, listening to music, reading a book, or having a warm bath. Resting when you can. Although we know it can be difficult when looking after a baby, try to sleep whenever you get the chance. And ask your partner to help with the nighttime feeds. Exercising regularly can help boost your mood. Eating regular, healthy meals and not going for long periods without eating. Not drinking alcohol or taking drugs, as this can make you feel worse. Ask your health visitor about support services in your area. They may be able to put you in touch with a social worker, counsellor or local support group. It can be reassuring to meet other women who are going through something similar. There are psychological therapies as well, and are usually the first treatment recommended for women with postnatal depression. There's guided self-help, which involves working through a book or online course on your own with some help from a therapist. The course materials focus on the issues you might be facing with practical advice on how to deal with them, and the courses typically last 9 to 12 weeks. The NHS apps library also has healthy apps and online courses you might also find helpful. There's cognitive behavioural therapy, also known as CBT, and is a type of therapy based on the idea that unhelpful and unrealistic thinking leads to negative behaviour. CBT aims to break this cycle and find new ways of thinking that can help you behave in a more positive way. For example, some women have unrealistic expectations about what being a mum is like and feel they should never ever make a mistake. As part of CBT, you'll be encouraged to see that these thoughts are unhelpful and discuss ways to think more positively. CBT can be carried out either one-to-one with a therapist or in a group treatment and will often last 2 to 3 months. Interpersonal therapy involves talking to a therapist about the problems you're experiencing. It aims to identify problems in your relationships with family, friends, or partners and how they might relate to your feelings of depression. Treatment also usually lasts around 3 to 4 months. There's medication, so certain antidepressants may be recommended if you have moderate or severe depression, and you do not want to try psychological treatment, or psychological treatments aren't helping alone. They may also be used if you have mild postnatal depression and a history of depression. Antidepressants work by balancing mood-altering chemicals in your brain. They can help ease symptoms such as low mood, irritability, lack of concentration, and sleeplessness, allowing you to function normally and helping you cope better with your new baby. Antidepressants usually need to be taken for at least a week before the benefits start to be felt, so it's important to keep taking them even if you do not notice an improvement straight away. You'll usually need to take them for around 6 months after you start to feel better. If you stop too early, your depression may come back. For severe postnatal depression, you could also have other treatments through your specialist mental health team, which include more intensive CBT and other psychological treatments such as psychotherapy. Therapies such as baby massage to help you bond better with your baby if that had become a problem. Different kinds of medications. If it's thought that your depression is so severe that you're at risk of harming yourself or others, you may be admitted to a hospital or a mental health clinic. Your baby can either be looked after by your partner or family until you're well enough to return home, or if you are lucky, you can stay in a specialist mother and baby unit, which is close to home. And here are some local support that are charities, so the NHS and your local professionals can help you, signpost you, and all of these are self-referral into and usually have peer-to-peer support as well, and can help support you through your journey, and meet other people who are in a similar position can also help as well. The references are there for you, and all the websites are there for you to have a look into any further detail if you want to. And for me, thank you very much for listening. So we have got some questions that have been previously sought from some of our local mums.
What does the prenatal mental health start and how long can you suffer for?
Kieran, do you want to come in?
Hi, thanks for that, Deca. Yeah, the perinatal period it starts as soon as you become pregnant, really, and we now know, and we now support women up to a year after they've had their baby. But there are also moves to extend that support, especially with women with complex perinatal mental health needs, and that might be getting extended now for 2 years, because we know women can suffer for a long period of time after they've had a baby. And yeah, so it's anything from when they become pregnant to up to a year after they've had the baby, but with a view of extending that to 2 years.
Yeah, I just wanted to say it's not a maybe, actually. We are in the throes of extending that in line with the long-term plan across the specialist teams to 2 years. And I think some IAP providers are already started doing it. So it's in the pipeline. We're just getting our staffing numbers up and recruitment, which always takes a while, so that we can start delivering that. But it's you know, Kieran, it's not, you know, it's great that you mentioned that, but it's definitely not a maybe. It's a definite that's going to happen, and hopefully by the end of the year we'll be in a position where we're saying yes, women up until the age of 2. But we're just trying to iron out at this stage what that looks like and how that's delivered.
Amazing, thank you.
Thank you. The second question is, what are the long-term consequences of perinatal mental ill health if left untreated?
Yeah, I mean, one of the biggest things and the joys of working in perinatal mental health, it's the truest form of early intervention in healthcare, because we know, and the evidence is, unresounding in this area, which is that mums who struggle with their mental health, not just even postnatally, but even while they're pregnant, it has an impact on the child, unborn and even afterwards. So we know that the effects of being unwell, while the mechanisms are not always entirely clear, they're quite complex, but we know that the exposure to stress, trauma, all has an impact on the baby. And it's not just the environment that, we know that now epigenetics, which is that genes are changed by stress. We know there's a huge complex relationship between a mother's exposure to stress, even while she's pregnant, which, it can result from her having untreated mental illness, has outcomes for babies of their own risk of mental health difficulties, but also physical health problems, whether that be developmental delay. And add into that, when a baby is born, that very early informative period of forming a bond with their baby, that attachment really relies on mums to be receptive and able to engage and be responsive to their babies. Mothers who aren't well, and significantly so, that can be quite compromised. Their ability, with the best of intentions, that can be quite compromised, and we know that has an impact on how children develop, their language skills, their global development, in not just mental health wise, but physical health wise is all impacted. So if we can support moms to be as well as they can be, we're making a difference not only to them, but hopefully to the long-term outcomes of their babies and their children.
Thank you.
Yeah, I think it's such an important question, and it is amazing how much help is available now, and it really is making a difference to these women who are suffering an early intervention. Even sometimes women can access support preconception. So if they if they've suffered severely last time, or they're really anxious about having another baby after following trauma or postnatal depression, they can actually access help and support even before they become pregnant, especially if they're on medication and need some further advice. And yeah, we know that the actual long-term effects on the whole family, and especially even the fathers, and we're becoming more and more aware now of the impact on the whole family. Living with someone who's suffering from any perinatal mental health has an impact on the children and the dads or the partners. So yeah, it's really important to support the whole family. Eunice.
And that's the great thing about the new services that are being developed all over the country and in Cheshire Merseyside, that they will be including the wider family and carers as well, within any treatment and support for that reason. So yeah, thank you. Decca?
Yes, I have another question here. Once you have suffered from a perinatal mental health, can you suffer again in future pregnancies? What are the statistics of you having it again?
I suppose the short answer is, it depends on the diagnosis. When we talk about mental health, there's a huge spectrum of different types of mental health diagnoses, from your very severe, women with schizophrenia, bipolar 1, to not to suggest they're to be minimized, but milder forms of depression, anxiety. So it's a complex answer to say what the prognosis is. It very much depends on the diagnosis. Certainly we know women with mood disorders like bipolar affective disorder, they're at significantly high risk of relapse, and increasingly, whereas previously mental health services only really used to take on and support women who were actually unwell, because we know there's such a strong link between that diagnosis and that diagnosis and relapse in the perinatal period. Services like mine would happily just take on women who become pregnant with that diagnosis, even while they're actually well, because we know that preventative work is so important. I suppose the other thing to just bear in mind here is that the relationship between mental health and social issues, also there's a big interplay, and that can add to the complexity of prognosis. So a woman with a mental health problem who also has maybe a substance misuse problem, has complex physical health issues, there's environmental issues such as poor support in the home environment, social deprivation, all of these together compound the prognosis. So while it's hard to give you statistics, but what I can tell you is that certain diagnoses are particularly high risk, and we would, services like mine, the specialist team, would take on women regardless, even while they're well, because the link is so high. But the positive thing to say here is a lot of women who haven't had a service or support in the past do really well if all the right support is put in place, and it can be really, really valuable preventative work. So, you know, it's not uncommon for us to have women who, for their second pregnancy, now that services exist, we've managed their medication, we've done invested a lot in support and early identification of relapse symptoms. And a lot of these women have needed very little input and have certainly not had significant relapses. So, you know, it's a very positive outlook really for women. If they get the right support, a lot can be done to prevent relapse in future pregnancies.
And I'm a personal kind of show of that really, because I had postnatal anxiety and depression with my first and my second, but then the third time round I was a lot more armed, a lot more support, and actually there was no diagnosis in the end because of the support and everything that I put in place. And I think knowledge is key as well. I think when you've had it once before, you are armed with it, and so are the family. So it's key to know, and kind of, I suppose for me, I would say make sure that when you are speaking to your family and friends, that they know the signs and symptoms to look out for, so that it's caught early enough, so that you don't go onto that spiral down and you can get that support early on. So I think knowledge is key, and I think that's the biggest reason as why we're here as well. And there's a lot more support now than when I suffered 12 years ago.
Yeah, I agree with that.
Especially when you cannot recognize, you know, all those symptoms, whether you are really suffering from mental health or baby blues and other symptoms that happen during pregnancies and after birth.
Absolutely.
Yeah.
I think we see a lot of women coming through who've had severe postnatal depression, and there's a big fear, you know, will they get that again? Because the last thing they want is to be in the place where they felt they were never going to move on from, you know. And so a lot of it, as Danny said, and it's that support and that knowledge and that giving them the right, we do have the pathways and we do refer people to different services depending on what type of perinatal mental health they've had. Some women who've had previous psychosis, there is I think it's a 50% risk of reoccurrence in subsequent pregnancies. But the great thing is, with the specialist perinatal mental health teams and the psychiatrists there with them, with that support, things can be identified a lot quicker and support put in place a lot sooner. So the outcomes have been really positive for a lot of women who might have really suffered from a psychosis in previous pregnancies. But you know, any type of mental health in the perinatal period is really significant to the woman and the family. So it's a key question really. Will I suffer again? What's out there for me? How can it be stopped, or how can I make sure that I've got the right things in place? And a lot of women feel really comforted knowing that they've got a contact number, someone they can phone, they know where they're going, they know who to speak to. They might have crisis numbers if they need it. So all them things are put in place during the antenatal period. So when they've had the baby, hopefully things go a lot smoother for them.
Thank you.
Exactly, especially, you know, when in some cases that some of the ladies were saying, we are breastfeeding, how can we get help? They are worried about the medication, whether it will affect their baby. That's also a case that put people off from seeking help.
Yeah, and I think with that, that's where it's key to talk to your professional that you've got in touch with, whether it be GP, specialist midwife, or your midwife or your health visitor, because actually there are many forms of medication. Some work, some don't. It is a bit of trial and error for some people, but there are many that can be taken through pregnancy and during breastfeeding, and it doesn't pass through to the baby and affect the baby. And these are things that we'd have to discuss depending on what the diagnosis is and what they need. I took through both pregnancies, in fact all 3 pregnancies I had antidepressants, and I managed to breastfeed my latter 2 children and had antidepressants through that as well. And there was a clear discussion with the GP that I had to say that this is what I was doing and is this safe to do so. And there's lots of information on the NHS website as well that go through a lot of what the drugs are, how they pass through the membrane into the baby, or how it affects yourself and some of the side effects and things. So it's about doing some research to see, you know, if breastfeeding is something you're absolutely, and I know it is part of the Quran to do so for the first 2 years. So I know, you know, if don't let that put you off going and seeking support, because actually there will be medication that you can take and it will be safe to do so.
Thank you, Danny.
Yes, I have a question. You know, sometimes you see families, especially in Sudan, we have this, like, if somebody in the family suffer mental health, you will see like maybe his mother had, his grandmother had, his sister. Sometimes you find most of the people in the family, they have this. The question I'm asking, is it hereditary or environmental? Thank you.
Brilliant question. We as part of all of our assessments, we ask about family history, because it does run in families, and that's for pretty much all diagnoses. You will invariably find there is a huge link, more so again the more severe the mental illness, that it runs in families. But yes, it's actually another thing is one of our kind of red flags. Someone who might be quite well, but there's a strong family history, that would be another case for us to maybe just keep an eye on somebody, because we know there is a strong link. So yes, unfortunately, you know, it is one of those things that can run in families, but again, a lot we can do to prevent history from repeating itself if we can identify, support women, provide them with information, and do some good care planning.
Thank you so much. Thank you.
Excellent question. And I do, although we know that there is a lot of family, you know, links with other people who've had a family history, it's definitely a lot to do with your social context as well. So some people when they're having a baby, all types of things can happen. You know, they can suffer loss, bereavement, they can, you know, people can lose jobs, there's problems with other children. So there's always a lot to look at, you know, and Danny read that list out before, you know, it seemed endless, but it's the truth. There's so many things that can affect a mum while she's pregnant, that can have an impact on her mental health. And sometimes they can cope with 1 or 2 things, but then the 3rd thing comes along and it's overwhelming. So yeah, it can be hereditary, but it also is a lot to do with what's going on in her life at the time.
And the key message to think about is, if it's affecting your daily living and it's affecting how you parent and it's affecting how you get out of bed in the morning, then it's something that needs support and looking at. Whether you find you've got a diagnosis or not, if it's affecting your daily living and you physically are struggling to parent and do the daily tasks that you are as a new parent, then it's time to seek support. And whether that's from friends, family, a peer support group from a charity, there are loads of peer support groups around Cheshire and Merseyside, or whether that's a professional and talking to somebody, or that's referring yourself through to the IAP services and getting counselling. You can get CBT as a first line, and they, you know, you can self-refer. There is a little bit of a waiting list, but like I said, anybody with a child under 12 months old usually gets a little bit more priority than those that don't. So it's about just seeking that support and getting that talking, because sometimes talking about it fixes the world. Other times you need more intervention.
Yeah, I think that's a great message to get out there, because there is still a lot of pressure on women to be this all marvelous, amazing mum, you know, balancing all the different plates and you know, being able to cope. And one of the biggest things is that first step. If something isn't right, and it doesn't matter what that is, but if it's affecting you, to seek help, because the support's there. And sometimes there's still so much fear, you know, will my baby be taken off me? What's going to happen? You know, is it going on my records? And all these things are really, you know, stopping the woman coming forward for that support when she needs it. So it's really good to you know, get that message out there that these women, there is help available, and we're there to support them through whatever they're going through.
And if social services are actually brought into the part of care because it does become that severe, they're usually there to open a lot of doors and open a lot more support. There isn't there shouldn't be the fear that they're going to come in, take away a child, and that's that. Actually, what happens is it opens up a lot more support and it opens a lot more avenues, and hopefully will, you know, the last resort is to remove somebody's child, and they will do everything within their power to not do that. So even if, you know, the word social services are brought up in a conversation, don't be fearful of it. Open it up, accept it, and actually you'll be surprised how much support you'll get from it.
Yeah, Danny, thanks for mentioning that. It's a real thing to kind of really point out here. It's absolutely up as professionals. We want to keep kids with their families. It's the best outcome, and it's, you know, it kind of breaks most of our hearts to have to see a child have to leave the family home, because that's not a good outcome for anybody. And, you know, just thinking of social services, there's different levels of intervention, and the very first one is team around the family, which just speaks for itself, really. It's about putting support around the family to make sure that they can still carry on being a family. So, you know, we are always, I would say, you know, all the professionals I work with, I can without exception say, you know, their priorities to keep kids with their and mothers together with their families, because anything else is kind of not a good outcome, and we know that.
That's absolutely correct, really. Especially, you know, when the misinformation that people go through and they share, someone cannot be saved due to that. And which goes into our next question, which is, what is the first step to receiving help?
Yeah, the first step obviously is if you're pregnant, speak to your midwife. So that might be the midwife that books you in. She'll ask the specific questions and take a mental health history. Or if it's, you know, if you're thinking about becoming pregnant, see your GP if you've got concerns or if you want any information about medication. But once you're actually booked into the hospital where you're going to deliver, most hospitals now have a specialist perinatal mental health midwife who you can be referred to for complex mental health, and we all have that access and a pathway. So we're all part of the Northwest Strategic Clinical Network pathway, and we've got a pathway now that we work on currently, but there's a new one being devised. So it's evolving all the time and improving, you know, because there's different things that come up and different things that we need to add in. But that pathway helps us know which service to refer to, how to liaise with it. So it could be child and adult, you know, CAMS, it could be the specialist team, it could be the local community mental health team if they're already involved with that, the GP, the IAP services. So it's all coming together really with whatever we've got and working together as a team to enable people to have the best outcome both during the pregnancy and after they've delivered. So yeah, so we all work on the pathway.
It's talk to a professional, and the professional will guide you into and signpost you into the right system that you will need, depending on what you're searching for.
I just would like to add something that I've seen it in my it might not in this country, but I've seen it somewhere with the mental health. You know, because of the stigma, you know, the family sometimes and sometimes of the vulnerability that the person might be vulnerable, that killing themselves or go to throw themselves in the sea, get drowned and all this. So some people, they just lock them, like put them in the room and lock them like they are in prison. I think this affecting them more and more. I'm not sure, but what do you think about this?
I think that's not something anybody would recommend over here. We certainly wouldn't advocate. You know, we understand stigma is what prevents a lot of people from coming forward, but actually there are a lot of services now that are available in common areas. Areas where it's not mental health designed per se. So you can go and you can say, oh, I'm going to the library, for example, and they think you're going to the library when actually there's a support group there being run, or a local children's centre, you know, where you see your midwife or your counsellor. So don't let stigma put you off getting help, because actually there are loads of places where you can go now where you don't have to say I'm going for mental health support if you prefer not to. But locking somebody in a room is only going to isolate them more. It's only going to distress them more, especially when it comes to the anxiety and the OCD, the paranoia and schizophrenia and bipolar, that kind of effect. So yeah, definitely the key is seeking support and actually going out and seeking that, rather than, you know, hiding anyone away, because that will just enlighten the situation and put more gas onto the fire than's needed. I don't know, Bev or
yeah, I mean that sounds like desperately sad to hear. Because basically by doing that, this, you know, a woman is being denied any help, really, because there's nothing helpful about being locked in a room, and if anything might reinforce any negative view she has of herself of being an inadequate mother, really, isn't it? Just there's nothing progressive or good that can really come from that. What I'd say, just to add to what Danny said, is, you know, the discreetness of what we can actually do. I mean, even in the specialist team, even though we're probably at the further end of the spectrum, but if a woman, you know, if a family member thinks she should be seen, you know, we'll go out to the cafe. I mean, obviously lockdown limiting this so far the past year, but we'll see people in a non-clinical environment if they would prefer, so long as we can maintain some sort of confidentiality. We've gone for walks with people in the park and spoken to them there. So, you know, it doesn't have to be that if a woman needs help and it's going to be too stigmatizing either for her family to feel they can bring or for her to come, you know, we can work around that. For some women, you know, the issue around bringing their children is an issue, and we will make whatever allowances that are required to try and get women to come with their babies. A lot of our groups, it's absolutely fine to bring your child with you, which I know sometimes women feel they can't always do in other sorts of settings. So I'd say, you know, get that, contact someone and speak. And then if there are things that are going to hold back a woman from being able to get help, let us know what it is and we can see what we can work around it, because we will do what we can to ensure she gets the care that she needs, and trying to make it specific to her needs if stigma is an issue.
Thank you.
Absolutely. I know when me and Kieran did the park walk, they really benefited from that, just being out in the open, a bit of fresh air, walking around the park, chatting to each other, and nobody would have known. We were just some women meeting together, showing each other our babies, you know, and having a wander. There was no stigma there at all.
I think it's a really important point, yeah, and agree totally with everything that's been said. And thankfully, we're moving away from that stigma now. I mean, everybody at some point in their life will suffer with mental health, no matter what walk of life they're in or where they've come from, and it's just really important that they know that they've got the support at this time, and thankfully we're moving away from the stigma that has been attached to mental health.
And mental health is just as debilitating as a physical health problem. You know, if you need a wheelchair, people will get in a wheelchair because that's what they need to be able to get mobility and move around. And sometimes medication and talking therapies is just as important for people to be able to get out of bed in the morning and actually function as a parent, as a person, and be able to survive the day-to-days of their own mind. And I think the stigma is slowly reducing. We've got a long way to go. Social media, as much as it can be negative in some respects from the perfect parenting and the perfect lifestyle, actually social media has got some really great positive affirmations and positive things from charities now, where they're trying to showcase that it's okay to not feel okay, and that everybody will feel something. And that rush of love as well, when everybody says they first see the child, and that instant love, and then the despair when that doesn't come. That doesn't happen all the time for every single woman that gives birth. Sometimes due to the situation of where they've given birth, due to the situation of how they've got pregnant, that rush of love doesn't always come, and that's okay too. It does come. It just sometimes takes a little bit of work with somebody than maybe it doesn't with somebody else. And that's okay too.
I think just wanted to expand on that, Danny, something certainly I've observed in my clinical practice, and I'm sure Kieran might say she has maybe identified the same thing as, which is social media, for all its wonderful elements. You know, the big challenge is this image that sometimes can be portrayed of what the perfect birth, the perfect delivery, the perfect body after you've had the baby, the perfect relationship, the perfect career, the perfect partner, and this is lending itself to subliminally give women this sense that they're inadequate if they don't have all of those things. When, you know, generations gone by, the famous saying, it takes a village to raise a child, which was women didn't do things on their own. You know, you didn't have to be all of those things, and it was okay that other people helped you and took over elements of care when you struggled. It was, you know, it wasn't seen as a failing necessarily, in the same way that now you're somehow supposed to manage everything at home, have the clean house, get back to work, have lost all your baby weight, you know, and it's, you know, it contributes to a lot of the stress that women experience, that if they don't fulfill all of these desirables, that somehow then they're inadequate and they're not doing their job well enough. And that's a piece of work in itself. I think as a society, we need to move away from this notion that being a mother means being all of these things perfectly, and it's too much pressure and it's not realistic.
Absolutely.
Totally agree, and we see it, and we do see it time and time again, and lovely mums who are doing so well, but they perceive themselves that they're not doing as well as maybe some of their friends are, or they're not as excited about the birth as some of their friends are, or you know, they're feeling really, you know, as Danny said, sometimes that connection isn't always there as soon as the baby's born, and then the guilt that goes with that as well, because everything seems perfect, especially on social media when you take a snapshot of what something looks like. But I think the beauty of it is that when we come together and talk, then people can realise, and it's about taking the pressure off themselves and lowering their expectations a little bit, so they don't set themselves up to fail, really, and just being supportive of one another. And you're right, this women have been so isolated, especially during the lockdown, which has had a big impact on mental health for people who've had a baby or who are pregnant, because you do need support from other people, and you do need to be able to have somebody to help you when you're not feeling the way you normally feel, or not being able to cope with things as much as you normally do. So yeah, the key is to connect together and to talk, yeah, and to speak up.
Absolutely, and one of the biggest advices that I always give to any pregnant person that comes through to me, or a friend of mine, is if somebody's coming to visit you, get them to make the brew, get them to bring the lunch, you know, because you have this image of, as soon as somebody comes to visit, they're here to see the baby, and you've got to play, you know, waitress to them, and you've just had a baby, you've just gone through all that. Let them make their own brew if they want to come and see you. Let them bring a sandwich, you know, for you, and bring a pie, or, you know, something that's already made, so that you can sit down and eat a proper meal together, you know, rather than you play host. And also, don't be afraid to say no. You know, if you don't want people to come and visit, just say no. It's okay, because I know I got out of hospital at like 6 o'clock in the evening, and by 7 o'clock I'd had 3 visitors, you know, and it weren't until I had my 3rd that I was able to just say, actually, no, I want this couple of days to recover, then you can come and see the baby. So don't be afraid to say no, just as much as you can say yes if you need it. That's been really informative, so thank you.
Can I just do a little bit of a plug for some expansions to the specialist team, just for everyone to know about? Is we talked a little bit about the partners element of things, and that's going to be, along with the expanding to 2 years, we'll be looking at what we offer. We're saying partners because obviously it's not necessarily dads, it could be a co-parent who's a grandparent, it could be same-sex couples, you know, so that offer is going to expand in support and intervention. But the other thing which we haven't really touched on, but I wanted to mention, was preconception support to women. So women of childbearing age, you know, preconception support and counselling around what needs to happen or needs to be understood, or reassurance that needs to be given to women in the lead up to them having a baby before they've even got pregnant, really. So we are piloting at the moment in Wirral self-referral for preconception counselling, and by the end of the year, hopefully that will be something we'll be doing across the whole footprint, which is women can not even need to have to ask a professional. They can pick up the phone and say, I want preconception counselling. We know that 50% of pregnancies are, roughly that's the statistic, are unplanned. So I don't even say wait till a woman wants to have a baby. If she has a, significant mental health history or has had complex treatment in the past, particularly perinatal related in previous pregnancies, women like that should be offered preconception counselling, and it's readily available. So that's a discussion about prognosis, what support might be available because they might be unsure, what treatment they might want to stay on or what they want to come off. And also they might have questions, women might have questions about, well, will my child be unwell in the way that I am? All of those questions can be answered and reassurance given so that women are in the best position possible, armed with all the right information before they even go into a pregnancy. So just wanted to add that little plug there.
That's very interesting. Especially I wanted to ask about if like a sister, not the pregnant lady, a sister see those signs, can she talk about it, and so that she get more information she can pass on to her sister, for example?
Yeah. So what do you mean if the sister is unwell or she notices the sister becoming unwell?
Yes, the sister, her sister is pregnant. She's not pregnant. Yeah, she just married and she wants to have babies, but she's not thinking about those things, so that she get informed, so she can pass on to her sister who doesn't want to come in, who's not aware of her situation.
I suppose the slight tricky bit is it's hard to talk about a patient without them being involved in the conversation.
Yes.
I see where you're getting at. I suppose what I would suggest is if the sister's worried, she could maybe support her sister just to say, look, there is these services available. There's such a thing now nationally across the UK called preconception counselling. She just needs to ask her GP at the moment to refer her, or we would accept her, as I say, self-referral will soon be the thing, but to encourage her just to phone and speak to somebody to refer her for counselling. And that conversation can be just 1 or 2 consultations with a psychiatrist, and we can just give information. It doesn't mean she has to change a single thing, she doesn't have to change a treatment, but we could just give her all the right information. So that's why I would say for a sister to do, if your sister's thinking about getting pregnant and she's worried, say, do you know that you can through the NHS get preconception counselling? Why don't you go and speak to somebody and discuss all of your concerns?
Thank you.
Thank you. All right, well, thank you so much for everyone that's joined us this evening. I hope you've all enjoyed it and found it as informative as I have. And thank you, Kieran and Bev, for all of your excellent advice and guidance there. We could talk all evening about this subject because I think there's such a wealth of information that we could give. So thank you, everyone. And if you need any advice, I will be sharing this on our website, improvingme.org.uk. And there are going to be some links on there as well to help signpost anyone who you think may need that support. And hopefully we can get everyone the support that they need, and nobody should feel like they can't. So thank you so much, everyone, and we'll hopefully
brilliant work, Danny. Thank you, and thank you, ladies. Thank you. Nice to meet you all.
Thank you, Danny. Thank you, everyone.
Yeah, thank you.
Thank you all.